Hello, my name is Dr. Quratulain Malik, and today we will discuss about pancreatic neuroendocrine tumors. Pancreatic neuroendocrine tumor is a bit of a mouthful, and we often use the abbreviation PANNETs when we refer to them. They get their name endocrine because they can secrete hormones. The pancreas has two important functions. The first is the production of enzymes that digest the food. There are little ducts that connect it to the cells that produce a clear fluid called the pancreatic juice, which is then passed into the main tube, and then that tube skirts it down to meet with the food and digest it. This called as the exocrine function of the pancreas. Then there are groups of cells called islets of Langerhans, which produce hormones, and those hormones passed directly from those cells into the blood vessels and finally into the splenic vein and then taken to the rest of the body, because these hormones will have effects far away from the area where they are produced. Those hormones include insulin and several other with very specific functions, like glucagon will reverse the action of insulin, gastrin increase the acid production, somatostatin has action on the gut including pancreas by reducing secretions, and lipoma is a condition associated with significant diarrhea. When the cancer arises in the endocrine cells, those that produce hormone, this condition is called a neuroendocrine tumor. PANNETs are classified into three categories: well-differentiated PANNETs, poorly differentiated PANNETs, mixed neuroendocrine, non-neuroendocrine neoplasm. The well-differentiated pancreatic neuroendocrine tumors are the most common one. Poorly differentiated pancreatic neuroendocrine tumors are also called pancreatic neuroendocrine carcinoma. It has a small cell or large cell type. The pancreatic neuroendocrine tumors are also divided by functioning or non-functioning type. Almost all pancreatic neuroendocrine carcinomas, the poorly differentiated ones, are non-functioning tumors. Functioning pancreatic neuroendocrine tumors include insulinoma, secreting excessive insulin causing hypoglycemia and related symptoms, even seizures. Chronic hypoglycemia can affect the mental condition, and some patients are misdiagnosed as neuropsychiatric disorders. Gastrinoma, secreting excessive gastrins which stimulate acid secretion in the stomach, resulting in Zollinger-Ellison syndrome, composed of peptic ulcer, GERD, diarrhea, and weight loss. Patients with glucagonoma develops 4D syndrome. Lipoma can cause WDHA syndrome, watery diarrhea, hypokalemia, aclohydria. Somatostatins can cause abdominal pain, diabetes, steatorrhea, weight loss by inhibiting other islet hormones. ACTH secreting tumors cause Cushing syndrome, and some of them may excrete the serotonin causing carcinoid syndrome. When the tumor excretes parathyroid hormone, patient develop hyperglycemias. Non-functioning tumors have no clinical symptoms associated with excessive hormone secretion, but tumor mass-related symptoms can develop, like abdominal pain, anorexia, nausea, or weight loss. They can also produce chromogranins, neuron-specific enolase, and pancreatic polypeptides. For imaging, CT scan done is pretty good, although the small lesions are hard to detect. And MRI, especially multiphasic MRI, is much more sensitive in detecting metastatic liver lesions. Endoscopy ultrasound is highly sensitive to detect very small lesions, and endoscopy ultrasound guided FNA can provide tissue diagnosis. Somatostatin receptor-based imaging include Octoscan Indium-11 provides 50 to 90% of accuracy. Gallium-68 ductate PET-CT scan is also highly sensitive and specific. Chromogranin A is the most commonly used marker for neuroendocrine tumors. It's sensitive for both functioning and non-functioning neuroendocrine tumors, and is useful to follow for treatment response or to check the tumor progression, but it's not sensitive for poorly differentiated neuroendocrine tumors. The level of chromogranin A is falsely elevated when patients take proton pump inhibitors like omeprazole. So the patient need to stop taking proton pump inhibitors 2 weeks prior to testing for accurate results. Pancreatic polypeptide is often used excreted by non-hormone producing islet cells and elevated mostly in pancreatic neuroendocrine tumors, but it has low sensitivity. 24-hour urine 5-HIAA hydroxyindole acetate acid is elevated in serotonin producing neuroendocrine tumors, mostly carcinoid tumors of midgut. The carcinoid tumors of hindguts or foreguts do not secrete dopa decarboxylase, which converts the serotonin to 5-HIAA. So, carcinoid tumor of foregut and hindgut will not have a positive 5-HIAA. Falsely high levels can be seen when patients take tryptophan or serotonin-rich foods. It's cumbersome to collect 24-hour urine, so gradually it is replaced by plasma 5-HIAA. For treatment of localized disease, surgery is the mainstay of treatment. For small tumors less than 2 cm without lymph node metastasis and tumor not close to pancreatic duct, pancreatic preserving resection can be done. Otherwise, traditional pancreatic resection, such as Whipple's procedure with lymphadenectomy, is the standard therapy. When the patient presents with metastatic disease at the time of diagnosis, and if those metastases are in limited numbers and tumors are well differentiated, then resection of both primary tumor and metastatic lesions can be considered. Patients with functioning neuroendocrine tumors or carcinoid tumors requiring surgery, you have to give prophylactic octreotide to prevent carcinoid crisis or other crises due to excessive excretion requirements. Starting 2 weeks before, during, and after surgery. During surgery, cholecystectomy may be done if patient need long-term octreotide therapy because octreotide therapy can cause gallstones. Poorly differentiated neuroendocrine carcinomas needs neoadjuvant chemotherapy before surgery or adjuvant chemotherapy after surgery, or locally advanced neuroendocrine carcinoma, chemoradiation therapy is used. For esophageal or anorectal endocrine tumors, chemoradiation therapy is given before surgery, but patients may not need to have a surgery if they respond well. For metastatic and unresectable disease, somatostatin analogs are used. Those drugs are octreotide and lenalidomide. They bind somatostatin receptors and inhibit peptide secretion. They may control tumor growth and the side effects are very mild. When the patients become refractory to the somatostatin analogs, then either chemotherapy or targeted therapy can be used. For the chemotherapy, the best one is capecitabine with temozolomide. For targeted therapy, sunitinib and everolimus are approved by FDA. A further treatment which has shown some promise is the peptide receptor ligand therapy, and these molecules are tagged with radioactivity which then fixate to the tumors and destroyed it by that means. Liver is the most common site of metastasis from neuroendocrine tumors. If feasible, surgical resection of metastatic liver lesions is preferred. Surgical resection is rarely done for poorly differentiated neuroendocrine carcinoma because of high reoccurrence rates. Anatomic hepatectomy or non-anatomic multiple wedge resections are done as long as over 20% of liver volume and 2 contiguous liver segments are preserved. But compensatory liver hypertrophy after resection may not be sufficient to maintain the adequate liver function when patients have pre-existing cirrhosis, hepatitis, or fatty liver. Tumor debulking may be considered as long as 90% of tumors can be resected. Local ablation therapy, including radiofrequency, microwave, or cryoablation, are indicated for small lesions. It provides symptomatic relief in most of the patients within 1 week. Other regional therapy include hepatic artery chemoembolization or simple embolization. Another regional therapy includes yttrium-90 radioembolization. The prognosis totally depends upon the stage of the disease. Thank you for watching.